All right, so we talked about cardiac dysrhythmias and cardiac arrest, and now we're going to talk about congestive heart failure. So I have to get there. Okay, on slide 14. So congestive heart failure is when the heart is unable to pump sufficient blood to meet the metabolic needs of the body. So it's usually a complication of another cardiopulmonary condition, and it may involve a combination of factors. So there are various compensation mechanisms that maintain cardiac output, and some of these may aggravate the condition in congestive heart failure. So in this picture, I don't remember if this one's from the book. I don't think it is. It shows a normal heart versus a congestive heart. So you get cardio hypertrophy. You get the heart muscle, because it's having to work so hard, it actually increases the size of the cardiac muscle, which isn't necessarily a good thing. Well, it isn't a good thing in this case. If you look at that in the congestive heart, you can see how there's barely any room in those ventricles to fill up with blood. So it drastically decreases cardiac output. So when the heart can't maintain its pumping capability, the cardiac output or the stroke volume decreases. So less blood gets to the various organs. So you get decreased cell function. You get fatigue and lethargy. You get mild metabolic acidosis because you're not getting the products of cellular metabolism out of the system either. So you get backup and congestion that are developing as the coronary demands for oxygen and glucose aren't being met. So the output from the ventricle is less than the inflow of the blood. That's the congestive part. So congestion in the venous circulation drains into the affected side of the heart. So basically you get backup of the fluids. So sometimes congestive heart failure presents as an acute episode, but it's usually part of a chronic condition. It can be a problem in the heart itself, like a myocardial infarction or a valve defect, or it can be caused from increased demands on the heart, like hypertension or lung disease can cause increased demands on the heart, or it could be a combination of all those factors. So depending on the cause, one side of the heart usually fails first. So, and then the other side, follows. But, so an infarction in the left ventricle or hypertension can cause the left ventricle to fail first. But pulmonary issues can cause the right ventricle to fail first. So, in the book, they show the different signs for the different sides. And I would like you to know that. There's a table on page 247, it's table 12.3, that has it compares left-sided versus right-sided congestive heart failure. So this is also from the book. I know it's super tiny here. And that's on page 246. You want to look at that. It's basically a cause and effect flow chart of congestive heart failure, of the course of congestive heart failure. So take a look at that on page 246. I think it's too small here. I can barely even read those little letters. But when you project this up on a screen, it looks a lot bigger. So the effects of congestive heart failure, we're going to get lots of signs and symptoms like fatigue, weakness, dyspnea, which is difficulty breathing, exercise intolerance, and cold intolerance. With either side, left-sided or right-sided congestive heart failure. But with left-sided congestive heart failure, a lot of times you get, for whatever reason, we talked about a few of the predisposing factors, but for whatever reason, the left ventricle weakens and can't empty. So that causes decreased cardiac output to the system. And so decreased cardiac output causes decreased renal flow, and that stimulates the renin, angiotensin, and aldosterone secretion. So that's going to affect your blood pressure. So you get backup of the blood into the pulmonary vein, and you get high pressure in the pulmonary capillaries, leading to pulmonary congestion or pulmonary edema. So when the left side's not working, so the right side is, at this point when we're talking about left-sided failure, the right side's still working, so you're still pumping fluid into the lungs, but it's not being pulled out enough by the left side, and you get congestion in the lungs with the left-sided heart failure. With the right-sided heart failure, the right ventricle weakens and can't empty, so you're getting less going into the lungs. You still get decreased cardiac output because not only is it not going into the lungs, it's also not going into the left ventricle, and you still get decreased renal blood flow, stimulating renin, angiotensin, and aldosterone secretion, affecting your blood pressure. You get backup. So in left-sided heart failure, we got backup in the lungs. In right-sided heart failure, you get backup into the systemic circulation, into the venous system. So you get increased venous pressure, and that results in edema in the legs and the liver and the abdominal organs. So you get that really high venous pressure, and that can cause distended neck, vein, and cerebral edema. So I don't know, it's a tough choice which is worse, but I'm going to have to choose. Well, they're both bad. Let's just say that. Right-sided heart failure is where you get the edema in the legs. Left-sided heart failure, you get a pulmonary edema, if you want to think of it that way. And then you can take a look at that chart on page 247 that compares the two, which is kind of nice. But if someone has congestive heart failure and they have edema in the feet, you know that it is the effects of right-sided congestive failure. You get the venous backup. So the forward effects, which are similar, whether your failure is on the left or the right, is decreased oxygen supply to tissues, general hypoxia, which causes fatigue and weakness, and dyspnea and shortness of breath. So that's both sides. Normally, the heart compensates by speeding up the heart rate, tachycardia, by constricting the cutaneous and visceral veins. So you get that cutaneous and visceral vasoconstriction. And daytime oliguria, which is the increase of the proteins in the urine. So the signs and symptoms of congestive heart failure have similar forward effects. It's the backward effects that change whether it's left or right. So left-sided failure, it's that pulmonary congestion. So you get dyspnea and orthopnea. So dyspnea, so anything with P-N-E-A on the end is breathing. So dys is difficulty, and pnea is breathing. So dyspnea is difficulty breathing. Orthopnea, ortho means position. So you can think of it as breathing position. So as fluid accumulates in the lungs, lying flat causes you to have difficulty breathing. So certain positions cause difficulty. So if someone has CHF, you do not want to lie them flat. You want to have them have their head elevated. So if they're in a hospital bed, elevate that head. If you have them in an outpatient clinic, get a wedge under them or something, or have them be sitting up. Otherwise, they're going to have difficulty breathing. There's often a cough associated with fluid irritating the respiratory passages. And they have what's called paroxysmal nocturnal dyspnea, which means they have tougher time breathing at night. They have acute pulmonary edema, and it develops more during sleep. There's an excess fluid in the lungs frequently lead to infections such as pneumonia, and pneumonia is one of the things that kills you. So that's one of the ways that congestive heart failure kills you. So one time I was working with a patient in the SNF with congestive heart failure, and I noticed that she was gurgly when she was breathing. And so I talked to the director of nursing right away. I'm like, she's gurgly. There's something going on. And she was getting backup of fluid in her lungs, and she ended up going to the hospital for a little while. They did medical treatment basically to get her fluid balance sorted out, and she didn't get better from the congestive heart failure, but she also didn't aspirate or get pneumonia because it was noticed and treated. So that's one of the things. We can't do anything to change their congestive heart failure, but we can notice when they're having trouble with some of these things and prevent complications. So right-sided heart failure, you get the systemic backup, you get that dependent edema in feet, legs, or buttocks. So if they're sitting or lying down, you get that edema. There's increased pressure in the jugular veins, and so they're often distended, and you can see it in their neck. They get hepatomegaly and splenomegaly. Megaly is enlargement. Hepato is the liver, so large liver or large spleen. You can't really see that, but sometimes that causes digestive disturbances because some of the enzymes that are being made in the liver are not there to digest things. Ascites is a complication when fluid accumulates in the peritoneal cavity, and you can see ascites because there's marked abdominal distension. And that person is miserable too. They are not comfortable. With acute right-sided failure, they might have a flushed face and distended neck veins, headaches, and visual disturbances. So that cerebral edema is what causes the headache and visual disturbances. So this is that chart from page 247 that compares the two sides. So check out that chart. Sometimes in young children you can have congestive heart failure, often secondary to congenital heart disease, which we're going to talk about in the next section, some specific congenital heart diseases. A lot of times with babies, the first sign they see is feeding difficulties. So they're underweight, they're not gaining weight, they're not meeting developmental guidelines. They sleep a little and then they get up. Older children, they're in a tripod position to play, and that is to help them with their breathing. So when you see children, you can, you'll hear more about this in your pediatrics part of your neurodevelopmental class, but the play position that children assume is if there's something wrong, it's often a position of less discomfort. So a cough or rapid grunting respirations, flared nostrils, or wheezing. And when you take x-rays or radiographs, it shows cardiomegaly in the child. And they use arterial blood gases to measure hypoxia in children. So in the next section, we'll talk about the congenital heart disease and how that can affect things.